primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever so relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
If primary care in America had to be stripped down to the studs, what I would refuse to leave behind is the doctor-patient relationship. That has to be at its core. I'm Dr. Matthew Hitchcock of Hitchcock Medical Group, and this is my DPC story.
What happens when a military officer, physician, and MBA walks away from the insurance system entirely and builds something better from scratch? Dr. Matthew Hitchcock of Hitchcock Medical Group in Tennessee did exactly that. Over the past decade, he's built a direct primary care practice that includes its own imaging center and pharmacy, delivering a CT scan, a diagnosis, and antibiotics in hand all in a single afternoon. Today, he's sharing why primary care fails when it's treated as a loss leader, why healthcare and health insurance are not the same thing, and how DPC can scale without losing its soul. Welcome to the podcast, Dr. Hitchcock.
Thanks for having me. Thank you.
I absolutely love that on your LinkedIn page, you have physician, operator, and builder. And I think that pretty succinctly describes, but doesn't fairly represent all that you're doing in Tennessee and beyond. So I'm just wondering, what does each of those words mean in the context of healthcare today for what you've been building?
I think, it kind of frames the lens that I kind of look through things at, physician obviously being at the core of this and kind of what informs kind of everything that I do for this. And, operator, we're doing this, every day. We're seeing patients and, kind of actually out there doing things, not just sitting in a C-suite somewhere coming up with stuff. Everybody in DPC is out there blazing trails and building a whole new system that actually delivers care where it's supposed to be delivered.
Absolutely. And I think that it's not like you could see those things on billboards from big corporations throughout the years, but like you're actually doing the operations and you're doing the building behind these things to actually make them a reality, like all DPC doctors are, which is so commendable and so incredible and so needed. So one of the things I wanted to ask you about, because, I've driven by Camp Pendleton many a time, and that's where you were at one point in your life. I just think
Good old
about
Camp Pendleton.
I just think about how you're very intentional about going forward. How did military training shape the way you think about leadership and system design, specifically when it comes to the world of medicine? Because I am assuming that you, at some point in your career, have felt like you're part of the system, especially in the military system. I don't know if you felt like you got personal attention.
Man, so many great things in that question. The military, I think the biggest thing, first and foremost, it taught me I never want to be middle management ever again for it. Just because I felt like a lot of times as kind of a 03, 04 kind of officer, I was that middle management that didn't really have agency from up or down for it. So I think that's the first thing. Yeah, but the military teaches you how to be a leader, just period, especially being an officer, or even some of the enlisted ranks. It teaches you how to take care of people, how to be a leader, how to get people to kind of align to kind of what you want to do and kind of the direction you want things to go for it. I think that was huge, being able to do that. And give me the confidence to know that, hey, I can go out and run my own business. I can do this. The military kind of really instilled that confidence in me. It also taught me that I can do things with less. There were a lot of operational times that we didn't have exactly what we needed, but, Semper Gumby, we had to kind of figure it out and, accomplish the mission with what we had available. And, that happens in DPC quite often for a lot of folks.
That it does. That it does. And I'm sure that people are laughing out there in terms of like, what have you been able to succeed with in terms of not the typical stocked cabinets of You can have like 20 IUDs stacked up. Like that's definitely not a thing that we have frequently in DPC. So I love that. And I think that also it really does speak to, especially those of us who are opening DPC practices and running DPC practices, like yours is a classic example of how you opened and you have grown. And I think that when we think about systems, it definitely helps us going forward to think about systemically what we're building. And I also wonder, you have a layer of an MBA on top of your on top of your medical degree and your time in the military. And I'm just wondering how that has influenced you when it comes to economic sustainability, because that's what we're really focusing on in this month. And you have continued to grow intentionally in this time of economic instability.
The MBA was great. I was about 7 years into running my own DPC when I kind of finally figured out, like, you know what, maybe I should actually go back and get an MBA for this. I remember when I first opened, our lender asked me for my P&L, my profit and loss statement. I'm like, my what? What are you talking about? What's a balance sheet? All these things. And just like in medicine, when someone starts medical school, we talk about medicine as a language, and you're learning a new language, and that's what makes kind of some of medical school hard at first. I think the MBA was the same thing. It kind of taught me the language of kind of business and finance, so I could understand a little bit more of what was going on. I could, look at our cash flow statements. I could think about capital budget planning for when I wanted to do an expansion like our imaging center, and kind of work through a pro forma and what that might actually look like in the future as I'm going through. And I could have conversations with CFO types or, finance types, and, speak their language and be able to relate to them what I was wanting to do on the medical side in terms that they would understand.
And I think it's just important. It's like when we're not talking specifically in medicalese to our patients and we're talking in a way that we're understandable to them. It's the same thing. And I think it's very strategic in terms of, again, systemically, you are very confident and trained now in speaking the financial language as you continue to grow. So the next thing I wanted to ask you is something that you said about primary care, in that it's treated typically in this country as a loss leader instead of an asset. And I'm just wondering, in terms of your personal experience with also feeling like a loss leader instead of an asset, what was life like for you before you decided to go on your own?
So primary care, a lot of times the value that primary care generates isn't extracted kind of at the point that it happens. It's extracted later. It's the downstream referrals, the lab orders, the imaging orders, the elective surgeries, all the things that happen out of primary care kind of being the gateway to a system. And I think that larger systems understand this. This is why hospital systems and big groups want to buy up primary care. It's not necessarily for its own intrinsic value, but it's all the downstream things that primary care can bring to that system. And I think that's where our system doesn't value primary care, in that it values primary care for kind of what it can do downstream, not in and of itself. The unit of care isn't the doctor-patient relationship. It's what value it can bring later. And those misalignments, I think, have kind of really messed with our healthcare system here today. And saw that, coming from the military, it's still, primary care, it's still, there's still insurance, there's still things in there. It's basically one giant HMO in TRICARE. And it's monopoly money, but it's still money. And I very much remember, this full schedule. I was there at Camp Pendleton as a faculty physician with the family medicine residency, and have a completely full schedule. And we get a memo from the command basically saying that our access is horrible. They're going to add 4 more appointments to our day. And I'm like, where? I'm already seeing patients from like 7:30 to 4:30. Like, where are you going to fit 4 more appointments? And it was about that time I saw a journal article about Josh, and I'm like, huh. This sounds absolutely amazing. Having a whole hour to actually sit down with my patients and practice good primary care the way I was trained. That never actually happens in actual practice primary care in the insurance world, but I could actually do so much good with that. And that's what landed me here over a decade ago now, doing primary care.
It's fantastic. And I'm just wondering if you can just give us a peek into your first year of DPC, because you were going from this system that you're describing to going out on your own. Did you just go crazy with like innovation and excitement because you were like able to do your own thing?
Oh, it was so much fun. Terrifying, absolutely terrifying. I'll give you that for it. Especially, 10 years ago, nobody really knew what DPC was. There were only a handful of us kind of in the whole country doing this. And yeah, absolutely terrifying is definitely the way I would describe that first year for it. But it was so rewarding to be able to do it. I remember the first patient ever, patient number one for our DPC practice here. I didn't even have a building yet. So getting my feet wet in commercial real estate and trying to find a place, which is its whole nother world of craziness for it. But I did it as a house call. And I just remember spending over an hour. We were always spending about an hour and a half sitting at his kitchen table, kind of going over his medical history and kind of doing all this, and just thought how amazing this was and how good I felt leaving his house that afternoon. I'm like, yep, this is it. This is what I'm supposed to be doing for it.
Incredible. And I'm sure that especially those of us who have had the time and intentionally do home visits, that's super relatable. And you
Mm-hmm.
just feel like, wow, like I just talked with the patient. You don't have to feel like, because you don't have to schedule,
Mm-hmm.
5 patients when you get back to the clinic. You literally can
Mm-hmm.
just do the home visits in a day.
Mm-hmm.
So, especially now in 2026, when we're recording this, I think about this quote unquote big, beautiful bill that has passed. And there's lots of reform always going on around healthcare. Reform is such an interesting word to use for that. But when it comes to actually getting at the core issue of primary care is where most Americans are thinking that they're going to get access. What do you think is off kilter about how we're doing reforms in this country to try to get at fixing healthcare access and quality for everyday Americans?
Oh, that's a great question. One thing that I think I see a lot with reforms that come from above us is that they focus on trying to make health insurance affordable and try to somehow conflate health insurance with access and care. And no, that's completely wrong. Until you talk about how we make health care affordable, you're never going to be able to have a conversation about how we make health insurance affordable. That's just never going to happen. And so many people conflate health insurance with access and care, and it doesn't work that way. When you really need to think about designing a system, it needs to kind of start with the patient and how they can access and how they can have relationships with their physician and continuity with them, where you have the same doctor and you know them, and I know my patients, and can kind of take care of them. And really, until you put that at the heart of any of these reforms, it's never going to go anywhere. You're still going to have this downstream muck where a specialist trying to do primary care, or patients are going to get their care at the most expensive site where that happens, be that at the emergency room or with a specialist, instead of with a primary care doctor who could have taken care of all this way faster and cheaper. It's never going to happen until you start having conversations about how we make healthcare itself affordable.
People, this is right here why I do my DPC story. Amen, Dr. Hitchcock. That is what it's all about. And literally, I had to put myself on mute because I'm like, oh, clapping away over here in California. This is exactly why also I love being around our community. I told my husband this last night. I literally love talking to rational people because it's really hard to talk to irrational people who literally think that health insurance is healthcare. So amen. I applaud that so much. And I hope that everyone listens to that because health care is not health insurance. Health insurance is not health care. And you'll go ahead.
I was gonna say it's so funny. We'll have that all the time. Patients are at DPC, they're like, "Oh, I have health insurance, so I'm gonna quit." And then, a couple months later, I get a phone call like, can I come back? It's horrible out here. I can't get in to see a doctor, and I just got sent to the ER for something you would have handled, and it wouldn't have cost me anything, and all this stuff." And people think that, oh, because I have health insurance, I don't need direct primary care or anything like that. And DPC is such a good front door to the system that people don't realize that.
That is so true, also. And this reminds me so much of how we talk about how we help people navigate the system.
Mhm.
And that's
Mhm.
something we get paid to do these days. And we didn't used to because even though we wanted to and we did things that help navigate the system for people, like nobody actually cared for compensation purposes. So it
Mhm.
definitely is much more rewarding that the time that you put in for things like that are included in DPC membership.
It's so great. I think a great story about this. A couple of weeks ago, I had a patient one Wednesday morning. She texted me with abdominal pain. I actually called her, talked to her on the phone real quick. I was like, hey, come on in. And so about 30 minutes later, she's in my office doing an exam. I'm actually thinking pancreatitis at this point. But here with what I have here, we were able to literally walk down the hall and get a CT scan for $250 for her. And we got the CT scan, and lo and behold, it was her gallbladder, now her pancreas. And I was, texting the surgeon, about it. He logged in and looked at the films, was like, oh yeah, sounds good. Had her in his office that afternoon and had her scheduled in the OR the next morning for it. And all because I had time and the ability to talk with the surgeon and to coordinate her care in a way that kept her out of the most expensive places she could have gotten that. And we got it all taken care of for her.
Amazing. And I'm sure at not the same cost that it would have been had she gone through insurance. Oh
Mhm.
my goodness. So here I want to ask about the lovely thing that we seem to quite familiar with these days is VC and PE funded healthcare. And so as we talk about these reforms from up where people are not actually practicing primary care, making decisions for us and our patients, you also now have from the economic standpoint, the VC and PE thrown into the mix, especially with your MBA background. I'm wondering if you can talk to the audience about could you ever have clinical integrity when it comes to the VC and PE funded models?
I think that's hard. With those models, really, a return on investment is what they're wanting, hands down, period. End of the day, what matters is return on their investments for it. And that is a misalignment with I think what physicians and what healthcare really wants. So that I think that's the first place that you get those misaligned incentives there. The other issue, like we kind of talked about earlier with primary care being a loss leader, they're just, especially in primary care, there just aren't the margins that you see in other places in healthcare, for it, where you can extract that required return on investment that these PE or VC companies want in the healthcare industry. And I think it goes back, a lot of them are kind of purchasing some of these like bigger systems for those other things to control the downstream things, or in some costs, maybe the data that's associated with it. The cynic in me thinks that's why a lot of these get bought up, is because there's a lot of data generated in primary care, and that might be part of it. But I think that's why you're seeing some of these kind of get into that and then go belly up. A lot of them, Carbon Health just kind of went, belly up earlier this week, and there's a few other things in there, and I just don't think that system's going to work in primary care.
It brought me so much joy to stand in front of Forward Health, which still has electricity in San Francisco. And I was like taking selfies and I made my husband take a picture of me because I was like, this is what happens when you have people who
Mhm.
don't actually do healthcare trying to do healthcare. And I think that like absolutely, especially being in rural America, I've said this to so many people in my community, but like we are preparing for even our local FQHC and FQHC equivalent to like go peace out on us because as a community, they already like my husband was already let go because they went to a non-physician model because it was cheaper. And that was before 2025. So, what's the incentive to stay if there's bigger money? And especially as one of our FQHC was incorporated into a bigger system that informed 60% of a county in Northern California that they were no longer accepting Medi-Cal patients 1 month. It's like that really is clinical integrity to me, people. Absolutely. Oh
Mhm.
my goodness.
Absolutely.
Yeah. So when we think about you opening Hitchcock Medical Group and specifically looking to do the DPC model, did you ever have any like maybe I could go hybrid, maybe I could just take a little insurance? Did you ever have one of those moments?
No, from the get-go, pretty much we said this is going to be pure DPC, as it goes. I'm not going to, be a hybrid and take, partially bill insurance or anything like that. We're going to jump in with both feet into the pond and just go for it, in the DPC model.
And you've alluded to it, and we'll definitely dive deeper into your imaging center that you've built as well. But I think about here physicians listening, and they're like, I couldn't do DPC because, or I couldn't not take insurance because. And I'm wondering, what do you see as the biggest misconceptions that physicians have when it comes to not practicing in the realm of insurance?
I think one big thing is they're going to worry about how they're going to get patients because in the traditional insurance model, a lot of the patients are just driven to them because they have their insurance and you're a network of their insurance and you don't have to do as much active marketing, especially in the primary care side of things. And I think a lot of physicians worry that they're not going to get those patients. And having to market yourself is a huge jump for a lot of physicians that we're just usually not comfortable with. Physicians aren't comfortable marketing themselves or talking about themselves or, striking up that working in that conversation when you're checking out at Target that, oh, hey, I'm buying this because I'm opening a new practice and doing this, and how you work those things into those everyday conversations. I think that's one big thing that I see with patients or with physicians who are worried about leaving insurance for it. And it's the system they've known forever. And, DPC is something new and possibly terrifying for them. And, there's no guaranteed salary as they go through stuff. And I think that's a terrifying thought for them too, for it. And then they're also worried about how am I going to order things for my patients? How am I going to order labs? How am I going to order imaging? How am I going to refer to specialists if I'm not in network or anything like this? And for the most part, it really doesn't matter. The patients can still use their insurance for those things if they want, unless you live in like a weird HMO kind of area where HMOs are popular. That could be an issue. But for the most part, I order labs and patients use their insurance for labs, even though it usually costs them a whole lot more than doing my direct pricing for it, or see a specialist or whatever. It still works just fine.
I definitely would say if you're listening and you are wondering, like, how would I do that in my area? Talk to a DPC in your state because there's DPC in all 50 states. So
Mhm.
it's definitely something a very understandable thing to be thinking about. And there's also a very reasonable solution in every state. So I want to ask here because you intentionally went away from insurance. Talk to us about what were the incentives that you experienced immediately and over time when it comes to being direct and transparent with your patients, with their care as well as their billing.
I mean, the first thing you notice in DPC is having time to sit down with patients. It's not the 7.5 minute or double book 15s or whatever you had before. You actually get time. In our case, usually it's about an hour to actually sit down and know your patients. It's not, I'm worried about the other two other patients I have roomed and I'm waiting for this as we go through. And, that shows up in little things. When we're working with an architect to kind of do our new clinic here, he's like, oh, yeah, every physician needs like 3 exam rooms. Like, no, actually, you just need one. Sorry, for that, because I don't have to have 3 other patients waiting as I'm kind of going room to room to room and worry about efficiency for that. And that's probably the first thing you really notice is time and having the time to actually practice good medicine and to know your patients.
It makes you think about the lines in the women's restroom versus like there's never a line in the men's restroom.
Nope.
Like if there was more
Mhm.
architectural input from people who actually use the restrooms, I think that we'd have
Mhm.
more of like a different arena when it
Mhm.
comes to restrooms. So yes, I totally appreciate that, and I think it's so relatable on so many levels. When it comes to you being a person to think about systems and you're going outside of the insurance world, you have intentionally gone into opening your own imaging center as well as integrating a pharmacy where patients can get direct access to wholesale medicines. So, versus staying a lean DPC, quote unquote, in terms of not having those options, what made you go down the pathway or what inspired you to go down the pathway of integrating imaging and pharmacy into your DPC?
A lot of these things were as I'm practicing DPC and I start running into friction points or pain points, like, how do I solve this? How would I do it? Pharmacy, just like most DPCs, we started off from day one dispensing for our own patients for it. And it was pretty easy when it was just me. It still kind of took time to kind of get everything. But as I brought on more physicians, 2, 3 physicians in, dispensing was almost turning into a full-time job for one of my nurses to get the refill requests in every week, to get the order in, to make sure we got it in on time, to get the meds entered into EMR, to get the labels printed, to kind of fill everything and do everything. It was almost a full FTE for one of my nurses. And actually, my wife Kathleen is kind of she's the operations officer, kind of the kind of real queen of everything is what I actually call her for this. But, she and I were talking one day. It's like, are we going to have to hire a pharmacy tech to kind of do this? How do we do this? And I got a cold email from a pharmacist who was unhappy with his job in retail pharmacy and like, hey, I see what you're doing. Is there a way we could work together? And we actually brought him on as a 1099 to kind of come in one day a week. And he was just so much more efficient at it than we were because that's what he does for a living. And we were able to kind of do that. And we're like watching it happen. And we have patients who would get a prescription from a specialist or, something like that, or, knowing it was a pain point for us. I'm like, you know what? Have a pharmacist here. Why don't we expand this? So we got it fully licensed, which actually wasn't a horrible thing. Got it fully licensed, and now our pharmacy part, Hitchcock Family Pharmacy, is a fully licensed pharmacy open in the outside world. So we have non-DPC patients who are getting the prescriptions through us for it, and we have other DPCs in town who are like, you know what? I never dispensed because it was such a pain. I was worried about keeping inventory in stock and going through stuff. And so now they just use our pharmacy. They send the scripts in just like they do any other retail pharmacy. We fill it and take care of it for them. And then imaging was kind of a similar thing. It was so hard sometimes to get the patients in imaging slot. Either they couldn't afford it or had to wait days with the prior authorization or all of these things. And a friend of mine from medical school is a radiologist in town. He and I got the crazy idea to open a cash only imaging center. And, here we are doing it. CT, X-ray, and ultrasounds for it, all for cash, no insurance, no prior authorizations. But that was a learning experience, jumping through all of the hoops with the state between certificate of need and the licensure for it, trying to kind of navigate all of those regulatory things to do it. But it has been absolutely fantastic, not only from the standpoint of here with the DPC being able to walk down the hall and get a CT scan or ultrasound or whatever, and literally having all the capabilities that a lot of these freestanding ERs have here in my office. But then just for the outside world, so many outside patients come in, like, we had one the other day, at a local imaging center. They quoted her like over $2,000 for a CT. I'm like, yeah, it's $350 through us. And we can do it today, not in, a week from now when we have time or when, kind of goes through everything. It's just been so good for patients to have that transparency in healthcare and to know what imaging actually costs and to get affordable imaging.
Absolutely. I know I've mentioned this on the podcast, but it's been a while. When I went to the Dominican Republic in medical school, we stopped by an imaging center where the radiologist owned their own facility. They sat the patient, they did the imaging, they did the report, they printed the report and the images on a CD, and the person would fly back to Miami and take it to their US doctor because for $350 plus the price of a plane ticket, it was way cheaper to do that. And
Crazy.
so, it's so crazy how it's it's sad that it's mind-blowing for patients to be like, wait a minute, it costs what? Like, it's so empowering to be able to do that, especially I can imagine when it's your own facility. Because I remember in Superior, Nebraska, I'd be like, hey, could you meet me down the hall in the ER and walk through the other door so that I can do my MRI that I need on you now? Because I can't order it from this clinic because I'm in the wrong hallway. And it's like the stupidest thing ever because you as a clinician, you as a physician are like, I actually know what I need, but it's the access part that is really hard for me to get it. Same with specialists when it comes to like, oh yeah, you're having heart issues, angina, 6 months maybe to wait. Yeah, that sounds good.
Yeah,
So I
that
can
works.
imagine the relief for our patients when they get this upfront
It,
care.
it's so nice. The story I love to tell, like before we had ours up and going, I had a patient with a kidney stone and, I send the order over to a local imaging center to like, hey, let's grab a CT and kind of see where it is. How big is it? Can you pass it on his own? And the imaging center calls me back and like, hey, can you send clinicals over? We'll try this. I'm like, oh, well, Blue Cross Blue Shield needs you to call them. And so I call them and talk to the lady on the phone and she's like, okay, sounds good, but it's going to take us 7 to 10 days to determine if he needs this. I'm like, he's writhing in agony on my exam table, and I have to walk in there and tell him it's going to be 7 to 10 days before he can get the CT scan. And her exact words were, "Well, if it's that urgent, just send him to the ER." And I'm like, "Where is the cost savings in any of this? You're more than happy to pay for an ER visit or make him pay for an ER visit rather than this, low cost CT scan out there." And just it's that access and all the bureaucratic things that hinder that are just absolutely insane.
And if your ER still remains after this year, because in rural America, I don't know if that's guaranteed, that's going to be happening way more. And
Mm-hmm.
so, it absolutely, again, it's like who is pulling the strings of this puppet that we call healthcare? When you're in the insurance driven world, it's a different set of puppeteers.
Mm-hmm.
Oh man.
Absolutely.
And when it comes to the sustainability of your DBC,
Mhm.
you have these layers of pharmacy and imaging that are accessible to your patients as well as your community. How has that impacted your long-term stability and economic stability in particular for your practice?
Been doing this for 10 years. So, growing kind of organically as everything's kind of grown up for it. But, being able to have all those pieces in the DPC really, I think, positions us as a great augmentation to someone with insurance for it, because again, insurance does not equal access and does not equal healthcare for it. And, positions us that patients be like, okay, I need this for it because I can get the lower cost imaging. I can get the access when I need it and not the middle of the night and just get sent to the ER or anything like that for it. And they have access for that. And then now, especially this year, so many people in the past few months have been reaching out to us basically saying, I can't afford health insurance this year. It's not going to happen. I'm going to go without health insurance and I'm going to have you because you can handle 99% of what is going to happen to me in a year. And I'm just going to take you and I'm going to roll the dice that nothing bad is going to happen to them. And I think that has this year, especially, has really kind of positioned us in a unique place for that.
When it comes to the autonomy that we have in DPC, one of the things that we are able to do is choose our own tech stack and our platforms that we use. And you've been doing this, like you said, for it's now over 10 years because it's already 2026. You're going towards year 11.
Mhm.
What do you love about and what do you hesitate about incorporating technology in different pieces of the tech stack into your practice?
I think the use of technology in medicine always needs to be intentional. My background, I was a chief medical informatics officer before kind of DPC for it. So I've always kind of lived in the tech world for things. My wife likes to call me a technopath. Technology just behaves around me for it. And always, anytime I look at technology in healthcare, I look at it through the lens of how does this either, support or detract from the doctor-patient relationship? And that's really where all technology in healthcare needs to live. And we need to think about it and that it should support that. Great example, when I was a chief medical informatics officer in the military, whenever I would walk into a room and someone was typing at the computer with the patient like behind them and they're paying more attention to the computer over here rather than the patient, I'm like, nope, nope, this is not what technology needs to be. It needs to be invisible if preferable and support the doctor-patient relationship. And so really, when we're looking at technology for the practice here, we look at ways we can do that. How can we support that from ambient documentation, which I think is fantastic because it gets to sit there and you catch everything and let me be present and talk to the patients and not have to worry about remembering everything to document, to kind of some AI kind of scheduling and kind of helping with some email responses for patients from my nurses to kind of help them kind of think through some stuff and kind of keep the tone consistent as they go through stuff, and just ways that we can use technology to support that human relationship that happens and really what is at the core of healthcare and DPC.
Here's a question because recently, last summer, we had our Battle of the EHRs come out and we had people, saying why they love, why they left, whatever, all these different things about their electronic health records in particular. And this summer, we're going to be doing the support technology that goes in addition to those electronic health records. But I think about in this world of healthcare and PE and VC, we also see that when it comes to technology solutions in particular. EHRs are coming up quickly. And then these are people who have had multiple startups in the past. Talk about acquisition of certain EHRs, certain DPC EHRs have been already, combining forces and saying it's a good thing. So I'm just wondering in terms of your outlook on sustainability of a practice if your tech stack just like completely goes out the window in terms of accessibility, in terms of your ability to talk with the company to say like, hey, I would love this change. You used to get that once it goes VC or PE, you can't talk to anybody anymore. What's your take on sustainability if you have to ride the wave of tech stack changes?
Oh, that's a great question. Because your EMR is so fundamental to kind of what you do day to day and kind of everything that you do. And when that gets disrupted, even if it's just, temporary for an outage or something like that, just, the wheels come off a lot of times. And that support aspect that you just mentioned, being able to call and actually talk to a human there, preferably the same human every time, especially if VC buys out something that might get eliminated pretty quickly as a superfluous expense for them. That's huge. Good support is always something that I rank, a software solution on, or really any tech solution on. If something breaks or, it's not exactly kind of what I like, can I talk to a person about kind of fixing that? So that is huge for it. And there's such a lock-in factor a lot of times with EHRs that and a lot of them intentionally kind of make it hard to switch, just so that there's some friction. So you don't want to just jump around like, oh, hey, this year I'm going to try this EMR for it. There's definitely an intentional friction there, from a lot of vendors for it, that it can be hard and it can really be challenging for a clinician if they don't love their EMR. Maybe they picked the wrong one from the get-go, to be able to like, I don't know how I'm going to love this. That can be a really challenging problem for that clinician, and why a lot of them, I talk to them, it can be, need to be intentional kind of on the front end, when you're evaluating the EMRs, really kind of think about what you want out of your system for it. Talk to other people, kind of what they like, because obviously when you're first starting off DPC, you may not fully understand exactly what you need out of a product until you're a year or two in, like, I wish it handled my communication, or I wish it kind of did this, for it. And that can be hard years in for it, just to make sure that on the front end, you're picking the right product for what you need for it. And, trying not to get locked into some of these things. And, hopefully they will, even if they get bought out by VC, kind of keep that customer support part, even though you're kind of starting to see a lot of that farmed out to AI and things like that now too. But, in general, I love competition. I think seeing more competition in the EHR space is good. It's going to kind of prompt some of the legacy folks to kind of add new features. You're kind of exploring new things as you're getting other competitors in there for it. Though a lot of the competitors are just kind of jumping in because they're entrepreneurs and they see a problem, or they see some money and they kind of might be able to fix this without having someone who actually practices medicine say, like, you may want to think about, having your EMR do this or do that for them. And, hopefully we'll see some improvement in functionality and kind of software across the board, just as there's more competition in the market.
Another economics question: when it comes to the economics of one's time, a lot of startups are, oh, we love your feedback, thanks for your feedback. What do you think about company balancing feedback to learn from physicians and physicians not getting compensated for that time?
Well, obviously, if you're the EMR company, you're wanting to do that as cheaply as possible for it. So that's kind of what you see if they can entice you some, non-monetary things, and especially some of these startups may be kind of lean, on their startups, so they may not have like cash resources to like pay the physicians kind of for their time as it goes through. So yeah, that can uncompensated expertise and time from physicians is, I think, a huge problem across the board for it. Yeah. Hmm.
I appreciate that, because it is important to acknowledge that,
Hmm.
we need technology, but also we are experts in being
Hmm.
DPC physicians, or future DPC physicians, because we already have experience in fee for service or residency. Changing lanes a little bit, when it comes to this idea that, I mean, we could have like a national debate about this. I feel, especially on the Facebook groups, some people argue that DPC can scale easily, and some people think that DPC is not necessarily something that should scale. So, in terms of your thoughts with systems and with the intentionality of your practice and the way that your community is getting access like it didn't before you opened, what is your opinion on can DPC scale?
That's a great question, and a question that does get hashed out on social media quite often for it. And I think it can scale to a degree. And you're seeing some people try the big kind of corporate national DPCs for it, and for the most part, they're not making it. One thing I noticed with One Medical, that as I was kind of in my MBA, kind of watching their financial statements, because in my accounting class we had to pick a company and kind of look through their, as we're kind of learning, financial statements, and I picked One Medical because they were kind of doing the closest publicly traded company and kind of what I was doing. And what I noticed were, as they grew in scale, they didn't publish this metric, but you could see their loss and you could see their total patient numbers. You could do the math and divide. Their loss per patient increased as they scaled. So very clearly, it wasn't a scale problem. It wasn't a, hey, let's just grow and try to outgrow this problem. So that wasn't the issue. And because as you scale anything like that, you're going to have to just by necessity add extra layers of coordination and, extra cost and people in the mix to kind of manage that as it grows. And that's going to by default increase your cost as it scales. And I think that's one reason why these big nationwide things aren't growing or won't scale very well, as much as if we could just get individual docs out there, one doc, two doc groups, and have those everywhere and convince, primary care docs that you either don't have to leave medicine, probably being the big thing because you're a burnout primary care doc. You don't have to go take a non-clinical role or just resign yourself to working for a hospital system. You can go open your own DPC as a solo doc and maybe have support systems for that one solo doc, whether it's, the imaging, it's lab, it's pharmacy, it's, some administrative things to kind of support them so that it's ready and easy for them to do. I think that is really how you scale DPC, because there's definitely something magic about a one, two doc DPC practice, that you lose when you go this kind of big corporate, nationwide conglomerate of DPC practices for it. And I think truly that's how DPC scales, is by ones and twos, like having these one, two, three small groups doing DPC out there at the small level.
And definitely, if you're a DPC practice and you haven't yet added yourself, there's a physician only DPC mapper that I've created specifically for patients called Caring. It's at caringdirectly.com, but you can register yourself. And basically, if you're not a physician led clinic, you get removed on the back end. So I know that that is a thing that patients are looking for. And I definitely would encourage everybody to just visit caringdirectly.com and add yourself on the mapper today. And it will be publicized when I'm releasing patient stories later this year. So it's exciting. And here, I think about One Medical, and I think that's awesome that you picked One Medical. Super, super smart. Just thinking about like all of the companies that exist in the world. I think that was a very, very smart choice. And it's so interesting to hear what you saw, financially as they grew bigger. But I'm wondering, could you envision Hitchcock Medical Group as a prototype for scaling in terms of the way that your culture exists and the way that you're hiring and the way that you're training people and the way that you're interacting with patients? Because you did open, as a smaller group compared to what you are today. And then yet you still are delivering what you opened to, what you intentionally wanted to in the beginning.
I think you can. I think you have to be intentional about as you're hiring clinicians and and bringing them in and making sure culture and what we want the patient experience to be is front and center as it's going through stuff. I think you can. And here with the whole medical group, the imaging center, the DPC, and the pharmacy together, there's just something magical about having all of that under one roof. And for here, that I think is harder to reproduce when you're just a DPC here and an imaging center down the road and the pharmacy kind of down the road for that. I love, and where I knew that we had something magical right after we kind of moved this new building, and we're still in the process of opening the imaging center, but we had the plain X-ray up. I saw a kid with a pneumonia and brought them in and saw them, evaluated them in the exam room. We walked down the hall, grabbed the x-ray, and then they walked back and I put in the antibiotics. And Robbie, the pharmacist, walked down. He was sitting on my couch in my exam room with the mom, and the kid had the bottle of antibiotics in his hand and was going over that with the mom sitting on our couch there. And I'm like, yeah, there's something special about this. I made the right decision. This is what we're supposed to be doing for here. And really being able to bundle all of that together under one roof for these patients is just magical. And that being said, it's still great for the other DPCs in town. Yeah, they use the Meyer Imaging Center. They send patients here. We get the results back to them fast. They use our pharmacy for it. But having it all under one roof, there's just something magical about that.
And in terms of the the collaboration you had with the radiologist who you opened the imaging center with, I'm wondering, you mentioned that you had to jump through certain hoops to get it off the ground. Damn those certificate of needs, man, I swear. But when it comes to like choosing equipment, did you
Mhm.
get new things? Did you get older things? Did you get things from facilities that have closed?
The ultrasound was new for it, but the X-ray and the CT were both refurbished for it. So those weren't brand new. The only thing for the CT, I had to set at least a 64 slice so I could do cardiac calcium scores for it. And that was kind of what we thought was kind of the bare minimum for what I needed to accomplish for it. But yeah, it was almost a 2-year process between the certificate of need and then licensure with the state to go from before we could open to the outside world for it. It was an ordeal and an adventure, kind of learning the ins and outs of all the bureaucratic hoops that I think prevent the competition in the imaging center space. And learn that a lot of the imaging centers here in Chattanooga actually aren't even licensed and don't even have certificate of need for it. They're just kind of rolling the dice. The state's not going to do anything to them, which I thought was kind of interesting. For when we were talking about the attorney, he's like, "Hey, you could, but I wouldn't recommend doing it that way." But it was a process.
I love that word. It's like that's like your 3 words. Physician, operator, builder. Process is a good way to
Mhm.
describe your
Mhm.
the hoops that you went through. Oh man. So I want to bring us back to the beginning when we talked about this idea that primary care in this country is really treated as a loss leader instead of an asset. I'm wondering in general if we stripped down primary care to the studs, what would we keep from your perspective, no matter where a physician is practicing?
I think the biggest thing is you need to keep the doctor-patient relationship at the core. That is really the core of primary care, but healthcare in general. And then you build it out from around there and you value primary care. If you look at a lot of other countries that have, way lower cost and way better outcomes than we do, they value primary care. They focus on primary care. Here in the US, more than half the doctors are specialists, and, because we don't value primary care and we don't pay for primary care. But that's what I would do if we were really going to think about redoing the healthcare system in the US, strip it down, start with the doctor patient relationship, and build everything up to kind of support that relationship.
If you've listened to Julia Louis Dreyfus's very first interview in her podcast with Jane Fonda, she had a power outage, and that's exactly what happened with Dr. Hitchcock and myself. I'm actually down in Sacramento now recording this because we still have a ton of snow from the snowstorm up in Arnold. So if I have different glasses and the voice sounds a little bit different, just bear with us. So picking up where we left off, I think about that saying, "Kiss, keep it simple," but I'm going to say, "Keep it simple." Smart doctors who are choosing to do
Mhm.
DPC, because we are definitely not stupid. We are definitely seeing the storm as it's coming, or as it's here. When it comes to financial structures, and particularly that need to change for primary care to be treated as an asset, what do you see, especially with your financial and economic background, as things that would be, low hanging fruit for us to change in this country, for us to value primary care?
I think, obviously, primary care physicians need to be, paid better and, drive an incentive for have physicians to do primary care as opposed to I'm going to go become a neurosurgeon because, the pain in the lifestyle and those kind of things, and really make that incentive to become a primary care physician for it. And along with the lifestyle considerations, with that as well, and which is what I love about DPC is, I can have a great lifestyle and make a good paycheck and enjoy what I'm doing for it, and hopefully encourage, medical students that, primary care can be a great opportunity for them. So I think that's one thing that needs to happen for it. I think kind of talking about models, I think a capitated model, which is exactly what DPC is, really is the way to go for it. Just because if you turn primary care into that kind of transactional, I'm just going to get paid per visit, I'm going to get paid per, metric that I can prove, then you get right back to kind of where you were, and you're not getting quality out of that. Whereas a capitated model, you get quality. My patients don't have to worry about how many, paying to come in and see me every single time, so they can actually get the care that they need for it. And there's no roadblocks for that. And I can, my incentive all of a sudden becomes to keep them healthy and to keep them away from me. So if, I'm getting paid whether you see me or not, my goal is to have you not see me. So I want to keep your diabetes under control so that I'm not having to see you every couple of months for, your diabetes being out of control or your neuropathy or your all of these things, that I am really working on your lifestyle and, what you're eating and what you're doing and your exercise and all of these things, so that you're, not an out of control diabetic and you don't have uncontrolled hypertension. And I'm taking care of those things. So I think more of that capitated a model like direct primary care is how one way you can, really kind of get some value in primary care and make it attractive for everyone.
It's almost like when you listen to what you're saying, this is why you can throw an opposition to every criticism about DPC that there is, because literally we're doing things sustainably, we're doing things profitably, we're doing things with the patient physician relationship at the center. So it's like you can't really argue with what you're saying in terms of the focus that we have at the heart of all of our practices. And, I think about Q-Liance in terms of like they, did have a capitated model. They were, for those of you who are not familiar with Q-Liance and the history there, definitely the very first, very, very big direct primary care model founded by Dr. Garrison Bliss and Dr. Erica Bliss. Definitely look up Bliss, BLISS, My DPC Story, and you can find their episodes. But I think that here there's always that proceed with caution if it's not physician led and physician managed. So what would you say in terms of growing sustainably, like you have, working with physician partners, growing into doing pharmacy and radiology options for your community as well as your DPC members? What would you say needs to be maintained by physicians as we go forward building, more systemic access to DPC?
I think physicians need seats at the table for every part of that. And I think that's probably the biggest concern with all of that is keeping physicians a seat at the table. Because when you start letting, unfortunately, kind of the bean counters and all those people start running it, physicians become metrics and they become cogs, and you lose a lot of autonomy and just the organic, wonderful growth as it goes. And so having physicians a seat at the table across the board is key for it. And I think the other thing too, and kind of what we're learning here with my practice, having the ancillary services, so the radiology and the pharmacy, and where primary care is, not having to stand alone as the primary economic driver of everything has really worked out well. In the beginning, the primary care was able to subsidize the imaging center of the pharmacy, and now, those are really kind of taken over for it, has allowed us to kind of grow without the pressure of, primary care, being a profit engine, which is, I think, what I have seen just kind of watching, other, larger tries at DPC. They've tried to extract value and have the primary care be the profit engine, and that just doesn't work. As you try to scale that up, it never, works out well. I think one notable thing, like with One Medical, when I was looking at their financial statements before Amazon, kind of bought them, as they grew, their loss per patient increased. So that tells you it wasn't a scaling problem, that, it's a, core business model kind of problem in that. And it's something you kind of really need to watch as primary care grows. And I just think you were kind of talking about it earlier. I think there's something magical about that 1, 2, couple of physicians, small DPC practice that you lose when it kind of grows and becomes this kind of big corporate monstrosity. And you get all these, and you start getting all these extra layers in there that have to be, fed. And I think that is what drives a lot of these big groups that have struggled as they've gotten bigger.
Like, as you're talking, I'm like, who in the audience has been bought out or experienced a buyout by Optum? Like, who? Because I think that that's going to be a lot of people raising their hands in their car or, as they're mowing their lawn listening to this podcast. So absolutely. I think that this is great food for thought. Well, thank you so much, Dr. Hitchcock, for joining us today.
Absolutely. Thanks for having me.
Thanks for being here for this episode of My DPC Story. Whether you stumbled across DPC for the first time today or you've been in practice for years, these stories are here for you wherever you are in your journey. And that's exactly how the Start Here page at mydpcstory.com is built now. It meets you where you are. New to DPC and learning the fundamentals? There's a path for that. Already practicing or in the planning stages and looking for practical tools? There's a path for that too. Ready to go deeper? That's covered. Head to the Start Here page at mydpcstory.com and find your starting point. If you have a question or a challenge you want to hear addressed on the show, go to the contact page at mydpcstory.com and leave me a voice message. And if this episode moved you, please leave a 5-star review on Apple Podcast. It's one of the best ways to help other physicians find these stories when they need them the most. For commercial-free episodes and extended conversations, check out our Patreon. There's a free tier and a paid tier, and both help keep this show going. Follow us on socials at MyDPCStory and find everything: episodes, free resources, the DPC Toolkit magazine, and more at mydpcstory.com. Until next time, this is Marielle Conception.